Hi, everyone. This is Melissa Wright. I am here guest hosting the ASES podcast on behalf of your normal hosts, Pete Chalmers and Rachel Frank. And this is a special episode where we have a little bit of a takeover from the Political Advocacy Committee. And so we have two great guests on tonight to talk to us all a little bit more about political advocacy and its role in the ASES. So I really want to thank Dr. Jerry Williams and Dr. Scott Steinmann for being on here with us tonight. Welcome both of you to the podcast.
Thank you.
All right, so let's just go ahead and dive on in. The first thing that I wanted to just talk to you guys about was why you both got involved in political advocacy and the Political Advocacy Committee of the ASES in the first place.
Go ahead, Scott.
I was just going to say, for me, it started actually back when I was in Minnesota. I got involved with the state society. I think that's really where things start. You really need to be, if you can, involved with your state orthopedic society. And I was on the board, and then I became president of the Minnesota Orthopedic Society. And I realized how important advocacy is. We had scope of practice issues that came up when I was on board, when I was a president. And then I was part of the BOC, and I was really surprised, actually, the first time I went to the first NOLC meeting or the first BOC meeting. I realized these guys are a key part of our organization. We do a lot I've done mainly educational stuff when I was at the Mayo Clinic, and now I'm actually meeting and talking about what's good for our patients, good for our profession. And I realized going onto the Hill and advocating for our orthopedic patients, and the NOLC gets maybe 300 to 400 doctors to show up out of over 22,000 orthopedic surgeons in the United States. So I think that really taught me the importance of being at the table, because you're not at the table, as to say, you're on the menu. And then since then, when I came down here to Tennessee and just being involved in ASES, I was always interested in working with advocacy, and Javier recommended that I get involved in the committee itself. And so now I'm co-chair, and Ted Sligo's done a fantastic job. He just rolled off as being chair, and Brad Bushnell is the chair of the committee now. We have about over 15 members, a very, very diverse membership, Melissa, as you know, and that's kind of where I am now. So thank you.
So for me, it was actually totally an accident. What Scott says about starting advocacy at the state level is really true. And it was, as I said, a complete accident. I was involved in the board of the Pennsylvania Orthopedic Society, and there was an attempt at the state level to write a workman's compensation bill that would have had very negative effects on orthopedic surgeons. So at the time, the Pennsylvania Orthopedic Society didn't even have a PAC. It was just a state orthopedic society. And we went to Harrisburg to speak to one of the people in state Congress about this bill and what we thought was wrong with it and what needed to change. And so we got to the congressperson's office, and basically it became clear to us that in order to speak to the congressman, we needed to have a check. And we didn't. So we wound up talking to the aide. We figured out that we'd get a check, come back the second time, and see if we could talk to the congressperson. And that's exactly what happened. So it became very clear to me that if you don't get involved with advocacy, and the check doesn't buy you anything except for an audience. You don't necessarily buy a direct result, but you don't get to see the people who make these bills and make these laws without supporting their ability to get reelected, because it's very expensive to get elected to public office in this country. So that's
Absolutely.
how I became involved in advocacy. And I realized how important it was. And I went on to become president of the POS. And then through my work at the Academy, it became apparent to me that from my perspective, state advocacy occurs with the Pennsylvania Orthopedic Society and other state societies. And federal advocacy happens at the federal level, usually through the Academy. And then when the Shoulder and Elbow Group, American Shoulder and Elbow Surgeons, decided that they wanted to get involved in advocacy, I think they made a very wise decision to hitch their wagon to the academy because the AAOS really does federal advocacy better than anybody. There's nobody that does it anywhere close as good as the academy. And so I'm very happy that the ASES is sort of partnered with the academy to be involved in national advocacy. And what I've just learned, as Scott basically said, the old story about you're either at the table or on the menu, is absolutely true. And it's just been crazy to me to realize how little people in our educated elected bodies know about medicine and the practice of orthopedic care. And
Yeah,
really, advocacy is all about making sure that the people who have the ability to influence laws and bills understand what the effect of those things are on orthopedic patients. And that's really the focus.
absolutely. So for somebody who, started thinking, hey, this seems important. I'm, looking at my patients and how care is being provided, and I want to get involved and make a change. What would your kind of advice be from just a really actionable level of like, what should those young orthopedic surgeons do?
I was going to say one thing is just to get involved both in your society itself. Most of the orthopedic societies, if you're a hip surgeon, certainly shoulder and elbow, they have an advocacy route. And I think back to when we get requests from donations to our colleges and universities we've gone to, it's important to start out early by notifying those folks that just graduated or just became candidate members of, say, the Shoulder and Elbow Society, and get them used to donating at an early level, a small amount, but just to get that practice going. And if you look back historically, the academy was started, I guess, in the 30s, but we didn't have the association was formed, I think, in 97, 98. We didn't have a PAC for the academy until, I think, 1999. And I think the first couple of years, all we gave was like $250,000 to candidates. And this past year, I got an email from Brittany Starr. We had 3.3 million that we've put in receipts, and we gave out 2.1 million to over 250 congressional candidates. So just look in the past 23 years what we've done, starting a PAC at the National Academy, as Jerry said. I think we need to be ortho partisan, and we talk about, oh, this is bipartisan, but certainly this year it's been even 50-50 split between Democratic and Republican candidates that we've supported. And it's been different in other years, but we look at those candidates that we can support, that support our mission, support our patients' mission. And I think that's the real goal to as Jerry says, to use the academy as a vehicle for the Shoulder and Elbow Society.
Jerry said you need that check to get in the door, and 2.1 million is a lot.
Well, the other thing is that I learned in the time that I was with the academy leadership, our office, the academy office, does such a good job of going to the Hill that there wasn't a single congressperson whose office we entered that didn't know who we were when we walked in. They knew the first and last names of our lobbyists. We didn't have to make any introduction. They know who we were. They knew why we were there. They knew what we were going to say. You can't put a dollar amount on that. That recognition is extremely important. But to your question, I think that when I look at the way that I got involved, I really do think that the simplest pathway and the most effective pathway, if you want to get involved other than financially, is through your state society. And if you're really active in your state society, you will rise up through the Board of Counselors in the AAOS and become active in the AAOS advocacy effort and the ASES advocacy effort just by being there.
Mm-hmm.
The other thing that Scott says that I just can't overemphasize, just to give you an example, I only know the academy numbers. I don't know the ASES numbers, but they can't be any better than the academies, maybe a little worse. If you look at the percentage of academy members that make a contribution to the academy PAC, it's around 35%, maybe even a little less. And the average contribution is around $300. That's what it was when I was involved. Maybe it's a little more now, but I doubt it. If you look at the trial lawyers, their percent participation is 99.9,
Wow.
and their average contribution is $1,000. So whenever I used to go around to the state societies and I talk to people at ASES who complain a little bit about having to pay people to do stuff, and they feel bad about it, what I tell them, and they don't feel like they get anything out of it, what I tell them is you need to spend about 5 times as much. So we need to not spend less. We need to have more of our members spend significantly more. If we want to compete with the trial lawyers and the American Hospital Association or other people like that, the people that we're competing against to try to influence things in Washington, D.C. spend way more than we spend. And there's a reason why when the Affordable Care Act was passed, there wasn't a single word in it about malpractice reform. Not a word. The fact that the trial lawyers, 99% of them contribute to $1,000, and the fact that there was not a word of malpractice reform in the Affordable Care Act are related directly. And if we want to have an effect, we need to have people get involved and donate their time at a state level and at their specialty society and at the academy. But you also need to let your money speak where your mouth is. It's just important. And I don't like any better than anybody else does. But the
And one
fact
of
of the
the
matter is, it's the way it is.
Yeah,
You know,
absolutely. And one of the reasons, I think we wanted to have this episode tonight is to, help our membership understand a little bit more about, what the advocacy committee does and, where those donations are going and what makes such a difference for our membership and for our patients. And I know one thing you alluded to was just how when you were going, to the Hill with the academy and, those lobbyists, they're known and they're really effective at their job because that's what they do full time. And I was wondering if you guys could talk a little bit more about maybe some of your experiences going to the Hill and how that's been kind of an important, advocacy learning opportunity and, just thing for you to be able to give back and do. It's something our political advocacy committee does. We go down to the NOLC.
I think it's important, as Jerry was saying earlier, is that there are literally thousands of PACs out there, and if we went up the hill, just tried to do it our own as a shoulder and elbow society, they just literally don't have time for all these PACs to come through.
Yeah.
And I think the trial lawyers almost double they give, close to $6 million a year. But we have to compliment ourselves. The academy's done a really good job. We're anesthesiologists give more than we do, but we're the second. The AMA gives less than we do. We give more than
Wow.
the AMA, and I think it's important to understand that, and that gets your foot in the door. So I think that's a key thing. Personally, when I've been on the Hill, I think the key thing, obviously, when I was in Minnesota, I meet with the Minnesota delegation here in Tennessee. I have my Congressman Chuck Fleischman's cell phone number, chatted with him on the phone. And so when I met with him, that was the best reception. I've given to his campaign, and, each of us on the delegation met with our own congressmen within Tennessee, and that's how it goes. And if you've given to them and they know you have, they give you the time of day. As Jerry said, these guys are always running for office every 2 years, obviously. And so they need support so they can, help you out. These issues take a couple of years to get going and voted on. So it's not just, you have to pay to talk to them. It's just how it goes. And I think that's a very important aspect.
So I'll give you a couple of stories about my involvement. The first one is pretty interesting. So this guy was actually a congressperson in my district that I didn't really know, but I eventually got in touch with him. He went to the same college I did, and I did contribute to his election campaign. But the point I'm trying to make is the relationship that I had with him, because we went to the same college, we sort of knew each other. It's those relationships that may or may not be founded on money. They might be founded on just the fact that your kids played in the same sports together or whatever. Those kind of relationships are really important. So I'll give you an example. I got a phone call from him from the floor of the House of Representatives. They were getting ready to vote on a bill that had something to do with health care. And he asked me, how should I vote? I
Wow.
told him, and he did.
That's
So the
pretty,
bottom line is relationships are really important. Sometimes they're more important than money. So one of the
yeah.
things that young people can do is get to know your Congress people, get to know the people who not only on the state level but the national level. Have relationships with them. Go over to their house for cocktails or whatever. You have a much better chance of influencing their thought process if you actually have a personal relationship with them. So the second story I'll tell you just has to do with um, if you are going to get involved in an organized way on the Hill with regard to advocacy, you have to make sure what your message is, and you have to be persistent enough and have enough gumption to actually make it. And I'll give you an example. So we went to the Hill, and it was when you guys may remember this, but I forget, I think it was CCJR was the original letters for it, but it had to be changed because Seth Greenwald told them they couldn't use CCJR. It was the first bundled payments initiative for joint replacements that the government was going
Hmm.
to run through Medicare. And I forget what they changed it to, but it was originally CCJR. And in the beginning, the hospitals were the only people that could own the bundles. So when we went up to talk to people on the Hill, it was divided about who would talk about what. We had various issues. And my issue was to make the argument as to why they ought to consider large practices that have the ability to control the bundle to have the bundle. So we went to Nancy Pelosi's office and we met with her health policy advisor, who had been in Washington, D.C. for 35 years,
Wow.
working for some politician or another. So he clearly was never in the real world. And I made this argument that physicians' practices make a lot of the decisions for what's spent, and we should have control of the bundle. And he said to a group of orthopedic surgeons and their lobbyists, you know, everybody wants the bundle. You guys are here today talking about the bundle. The nursing homes were here yesterday. Last week, the hospitals were here. Everybody wants the bundle. Somebody's got to look out for the patient. And I looked at the guy and I said, as I understand it, the only group that of all the groups that you just mentioned, the only group that took a Hippocratic oath to take care of the patient is sitting in this room. Okay. We're a bunch of orthopedic surgeons. We've been taking care of patients for thousands of years. We'll take care of them for thousands more. We're not here about who's going to look out for the patient. We're here to talk about the money. And the bottom line is that changed the entire tone of the discussion.
Yeah.
He understood that we understood the issue. We weren't there to bandy about with him. We were very serious. We had something to ask for him. And sometimes you got to do that. When we left that room, I wasn't sure I did the right thing. I said to Catherine Boudreau at the time, she's now married. I said, was I over the top? Did I do more than I should? She said they needed to hear it. And
Yeah.
so the point I'm trying to make is when you go to advocate, you do need to make your argument. You're not there to make friends.
Sure.
You're there to make your argument. And if they give you the floor to make it, make it.
When we go to the Hill, I remember we took care of one of my patients when I was in the Navy, was a retired submarine admiral. And he says, leadership, if you go to your men, don't go to them with more than 3 things because it's hard to keep everything straight. And it's only when we go to the Hill, it's usually 3 things that we want to, and the ask when you meet with your congressman, not 10 things. And I think each of these has a 1-pager, so they just have notes on it. So that's one thing that the Office of Government Relations and the Advocacy Council, Doug Lundy's done a great job there. There's no surprise when we go to the NLSC, it's been vetted about what issues we want to bring. There's a lot of issues we obviously have in orthopedics, but it's well vetted. It's not a surprise when we meet and before we go to the Hill of the issues that we're going to discuss. I think the Academy does a great job, or the association does a great job on that.
Yeah, one of the things I've been impressed by as I've learned so much being on the political advocacy committee is just how much is going on behind the scenes. You guys have both talked about your trips to the Hill and these moments where, there's always people doing this for us as people who maybe haven't been involved before. And when you start to learn that, so many of our, your colleagues are putting in their time, their energy to make this kind of stuff happen, it doesn't just happen magically where we're able to, protect some of our reimbursements, patient care, all that sort of thing. I want to talk a little bit about some of the kind of current issues that you guys see as, really particularly critical to orthopedic surgeons and specifically shoulder and elbow surgeons that, the Academy and the ASES Political Advocacy Committee have their eyes on right now. What do you guys see as, we don't want to go more than three, like, the top one or two things that we as surgeons should be caring about right now from an advocacy standpoint and kind of thinking about and staying ahead of?
I think from my perspective, the ones that I've heard most of, the hot ones, are this pre-certification issue with orthopedics. As you probably know, up until
Yep.
relatively recently, you didn't have to pre-certify orthopedic procedures. You didn't have to get permission from a third party about whether or not you might get paid for doing what you do. And it's become sort of a barrier, at least in many people's experience, between the doctor and the patient, trying to get the patient what they actually need. And I know that the Academy has been pretty vocal on Capitol Hill about getting some relief in that regard. And there's word that I think there is a sympathetic ear to some people on the Hill to that particular issue. The second one, which I'm not sure we're going to win. Scott and I are both old enough to remember the correction that was supposed to happen to reimbursement for physicians because of the formula that was used to calculate it, and they kept kicking the correction down the road year after year after year, and we just got used to them. We'd come up to where we were supposed to get a certain percentage reimbursement cut. We'd make a lot of noise, and they would say okay and kick it down the road another few years. This is the first time that they didn't kick it all the way down the road. They didn't take away as much reimbursement as they threatened they were going to, but for the first time in a very long time, they dropped some. So I think that's another issue. We may not win it completely, but I think we need to try to stop it where it is now. I think that's a second issue. Scott, can you think of any others?
Yeah, I was going to say, it's really eye-opening when we're talking about the conversion factor for Medicare reimbursement, and that was dropped last year. Last year it's always in December. We actually had about a 2.5% cut, not advancement, and we have inflation going on, and the conversion factor is 4.5% this year plus the 4% pay-as-you-go part. So we're looking at 8.5% cut that was going to come down to not just orthopedics, but all medicine, all physicians. And at the last minute that got changed. The pay-as-you-go got dropped, and we have about a 2% cut. So that's 2 years in a row, at least historically. And the pay-as-you-go is kind of hard to understand. It only came in the 1990s, as I recall, and every several years it gets dropped, and Congress says, "Oh no, we're not going to do it." But how it's supposed to work is, if you increase entitlement in one area, it has to go down in another. It has to be like zero sum. And so if you increase whatever area you increase it in, then it has to be taken out of other programs. And that's back in, but it was kicked down the road, as Jerry said, for a while. So, but if you look at the hospitals, both inpatient, outpatient, skilled nursing facilities, hospices, they have an adjustment for inflation that we don't have. It's an update that happens automatically every year, and the hospitals have had about a 60% rise over the past couple of decades, and whereas we, over the past 2 decades, have had essentially adjusted for inflation, about 20% cut of payments, which is not insignificant to physicians across the board. So, as Sherry was saying, I think we, like, why did the physicians get left out of an automatic update that all the other areas that receive Medicare dollars get adjusted for inflation? So that needs a serious looking at, and hopefully we'll do that. Other issues, physician ownership in hospitals, medical liability, that's been off the table for a while. As Jerry said, it wasn't part of the ACA. Prior authorization, some things that some state societies, Texas has started like a gold card program where they're about to start, whereas if over 90% of the time when you ask for imaging or the surgery you're going to do, it gets approved, well, then you get a gold card. And you get a sort of a fast pass to get these things approved. And Again, that's at the state society level, but the prior authorization has just been Medicare Advantage at the federal level, but we still need to fight for that from the state society.
If you look at the consolidation of the insurance industry, the Blues always have a whole bunch of different names for their individual parts, but they really roll up into the Blues. Nationwide, there's something like 5 insurance companies. And if these 5 insurance companies hire third parties to do the prior authorization, which basically means they wash their hands of it, it becomes a federal issue. And every one of these things needs to be couched from the standpoint of how it affects patients' access to care and patients' quality of care.
Absolutely. I think that's, really what all of this is about. It's about us being able to provide adequate care for the patients. And when you look at these cuts and stuff, that impacts how people are able to provide care as well, because private practices can't stay open, things like that. Obviously, these are big issues, and the political advocacy committee of the ASES is, works with the academy, and everyone's trying to kind of stay on top of it and keep these things from going the wrong direction. Do you guys have any thoughts on how, beyond the getting involved and forming relationships and contributing financially, do you guys have any thoughts on what we as surgeons should be doing to try and stop some of these changes or get things going in the right direction?
I think one area that is helpful there. Not many orthopedic surgeons are members of the AMA. I think it's less than 20%, I think for sure. But we've signed on to a statement that the AMA has put together and sent to Congress. I think it's important. A couple of things, they're asking for the annual update for inflation, which we don't have as physicians, and then to revise that whole pay-as-you-go budget neutrality to allow for appropriate spending. If there's things that are new that have been proven to be beneficial to patients and they cost a bit more, well, we should provide for that. And the other thing that I've learned is that we pass legislation, but it's the agencies that write the rules. And so when we go to speak with our congressman or go to the Hill, we have to remember that we can pass legislation, but then non-elected bureaucrats are the ones that actually write the rules at CMS. They interpret the legislation. That was eye-opening to me. And that's hard
Yeah.
to do because these are unelected people. But one thing that the AMA is encouraging, I think we should do, is collaboration with other societies and to encourage in the marketplace collaboration, competition, patient choice. But there's sort of this creeping sense, at least among the bureaucrats, of consolidation. And I don't think consolidation is, that's sort of moving toward a one-payer system, one universal health care, which may not be the best thing. But competition, I think, and patient choice and collaboration, I think, should win the day and not consolidation. That's what we need to, I think, look on the regulatory side. The regulatory CMS is, I think, probably just easier for them. They have to just deal with one way and one way to do it, and that's consolidation. And the payment models, I think, should be risk adjusted for those historically marginalized and potentially more expensive to take care of those populations. And I think government needs to support practices both in the rural and the urban environment where things work well, and not try and force one way for both urban and rural, and small and big. So.
Yeah, I think that's a great point. There's so much diversity that we appreciate in our patient populations and how we care for people. And there's not always a one-fits-all approach to things.
God is right that you do have to spend some time and probably some revenue on trying to influence the regulatory agencies. I can remember one issue in particular. The CMS had decided that they were going to get rid of the 29823 code for arthroscopy. And the rationale behind it was that they had decided that the shoulder was actually just one anatomical area. It did not consist of the sternoclavicular joint, the acromioclavicular joint, the glenohumeral joint, the subacromial space, the scapulothoracic joint. It was just all one cavity. And as a result, they would only allow one code, no matter what you do. That was their rationale. And so we met with them twice. The first time, I didn't think we had a prayer of getting anything changed. The second time we visited them, they actually put the 29823 code back on for certain cases that you would do with it, but they still did not give up the fact that they thought that the shoulder was just one cavity. And now we're sort of revisiting that 29823 thing again for the same reason. So you do have to stay on the regulatory agencies too. It's not just the legislative people on the Hill. Scott's right. When the bill gets passed and it goes to the regulatory agencies to enforce it, sometimes they're the ones that change the rules and make the rules, and you can't lose sight of your regulatory efforts in to the sole emphasis to the legislative side of things. You got to look at both sides. That's absolutely true.
So is there hope for us?
Well, I always say, here's the thing that they can never change. Okay. And the one thing I was going to say is our biggest advocate is our patients.
Yeah.
And don't be bashful to use your exam room as a way to make arguments that are good for your patients that you're staring at and taking care of patients. Don't ever forget that. And the one thing that they can never take away from us is the fact that we're the doctor and they're the patient. That can never be taken away. So I think what we focus on and what we focus on currently and what we need to focus on is everything that we advocate for allows us to provide the best quality care to our patients that they deserve and they want. And that's what we're advocating for. And as long as we make that argument in that way, I think we always have a chance.
Yeah, I agree with Jerry 100%. There are some Congress people on Capitol Hill that, if you're coming as a doctor, representing doctors, you're probably not thought as being underprivileged and such. And so, having a concise message about our patient stories, it's not about us. We should remember that. It's about helping our patients. And in some areas of medicine, if you work in an academic center and you're just paid an academic salary, or if you're in the military, you think, well, this doesn't benefit me. Well, it does, because, for example, this past year, based upon our Academy Association, we've gotten more money for orthopedic research dollars from the NIH, and that we've been able to increase that. And if you look across the board of what's the biggest cause of lost work, which is expensive, right? It's all musculoskeletal.
Yeah. That's
the biggest one. We spend 6% of our GNP on musculoskeletal issues, and that's a lot of money. And these are people working, contributing to society that are not at work. And so we need to have the money, research dollars to focus on that, and we have. And as I go back to what I said earlier, the anesthesiologists are giving more than we are, but we're number 2 among the medical PACs, as I said earlier, ahead of the AMA. And so we're doing a pretty good job, and I think we can do even better. The ASES, we have 19% of our members are contributing to the PAC, which is actually pretty good. It's actually high up there among the different societies. Hip and knee is much less. But I think a goal that we should have as the ASES is, and we plan on this at every annual meeting, to have some presentation on the PAC and how we can contribute to that. I think over the next couple of years, we should be able to get up to 30%, which would actually sounds low, but it's actually very high for our organization. I think we can get there. And one thing that the Academy has done is it started the Advisors Circle. As an individual, you can give up to $5,000 to a PAC. But a corporation, LLC, and Rothman has done a fantastic job of being part of that advisor circle, which is an LLC or corporation. It's unlimited. That's soft dollars, but we need soft dollars to keep the lights on and run the office and pay salaries and stuff in DC. And so that's been fantastic. And the ASES is part of that also. We contribute about around $25,000 a year in the soft dollars to the advisor circle. And from that advisor circle, one of those has a seat on the PAC executive committee of the PAC. to bring those issues. So I think there's a lot of good things that we're doing, and I think it's going to get better personally.
I just love that you said, it's like we're doctors advocating for patients. We're not doctors advocating for doctors, and that's I think an important thing to remember. But go ahead, Dr. Williams.
But what I was going to say is, Scott's right. From medical PAC perspective, we're always the academy's always number one or number two. It goes back and forth between us and the anesthesiologist. The big thing that drives the anesthesiology money is scope of practice. The CRNAs and the anesthesiologists they're at each other's throats sometimes. And the bottom line is that's a big issue for them, and that's what drives their money. If you think about it, though, if you look at what anesthesiologists make in comparison to what orthopedic surgeons make, we ought to be number one by a mile, to be perfectly honest with you. So I'm happy that ASES is at 19% and the academy's at 30%, but I'd be more happy if the ASES was at 38% and the academy was at 60%. If we had that kind of contribution, we would be known even better. We're known on the Hill now because we make a lot of noise, and we make a lot of noise in a very organized way. We don't show up with a shotgun. We show up with very accurate firearms, and we have the same message, and we shoot for the same target every single time. They know when we come back, they know what they're going to hear, and when they know that we're going to pound them on it, and that's why we do what we do. With what I considered, if you consider it compared to other medical PACs, we're great. But if you compare it to the people we're really fighting against, insurance companies, hospital associations, trial lawyers, we're coming to a gunfight with a knife. We need more ammo, and we got tons of firepower. I mean, nobody is smarter than the people that we bring to the Hill and the people that we have in our midst that are involved in advocacy. Scott, Ted Schlegel before him, we have really smart, capable people. And if we could get just a little bit more support, we could have even a better effect. And we do a good job. I agree with Scott. We do a very good job, but we could do a lot better. And this is not going to change. This advocacy, the way things work in advocacy and the way things work in legislation and the way care is delivered, it's never going to change for the better. So we just need to keep fighting. And then I'd just like to emphasize a number that Scott gave a little minute ago. It's a number that's kind of hard to get your arms around. So this was pre-COVID. The amount of money spent in the United States on healthcare was $17 trillion a year. A third of that. A third of $17 trillion a year was spent in musculoskeletal medicine. So, and if you combine that with the fact that orthopedic surgeons, I think, still have the highest reimbursement of any specialty in medicine. So not only do the legislators not like us, some of our colleagues in other fields of medicine don't like us that much. So the bottom line is we have big bullseyes on our back. We have to realize that we got to fight every single day for our patients, and we got to never get sick of it. Yeah, and it's hard to get sick of. I mean, it's easy to get sick of. I mean,
I agree. Yeah. One thing that I realize, I've been a member of the ASES for a while, and I really think that the PAC committee or the PAC contributing to the PAC is a very, very key aspect. I mean, when I was chair of the membership committee, I think that was important. The new members were getting in. But I think along with that, I think having a strong presence in the Academy PAC, which we have. And I think back to, a couple of years ago at the BOS meeting, we got 100% participation from BOS members, but it was because I think Kevin Plancher was the president. I guess it was 2 years ago. So everybody pick up their phone and dial, text 41444 and type in AAOS and give $25. And we should probably do that at our annual meeting at the ASES. I mean, it's easy to do. But one thing also that politicians look at is percent participation.
Mm-hmm.
We're behind anesthesiologists, as Jerry said. They're a one-trick pony. They just concerned about the CRNAs. Is if they see that we have over 30% participation, if ASES can get it's hard to get above 50 in any of these. But if at the annual meeting we just say, pull out your phone and give $25 everybody right now, that would give it the percentage of participation, even though it's a small number. That still is a powerful message that is sent to Capitol Hill.
Absolutely. I know our time's going to wrap up here pretty soon, but I wanted to, ask if you guys kind of had sort of parting words of what you think the most important role of the political advocacy committee is for ASES members, and kind of what they should take away of knowing this committee is doing for them, and why it's so important.
I can maybe start. One thing I didn't want to forget to mention is Mark Frankel has funded an award. It's the Healthcare Policy Award. They call it the Frankel Award. It just started in this year's. Melissa, we're funding 3 new members to
Yes.
go to the LSC, and as part of it, they have to do a project on advocacy. And I think those reports that we'll give at end of each annual meeting, I think are very important. And Claude Jarrett is working on the prior authorization study from the ASES perspective, which is great. But I think having the word out there is knowing what's going on in Capitol Hill and giving a message back to our members and encouraging them to contribute.
So from my perspective, I think Scott, we're both this way, I know, but I know Scott knows that I am. I really think that your focus needs to be on your patients. And if you really want to guarantee or do the best you can to guarantee that you will be able to take care of your patients in the way that you see fit at the end of your career, and you're now just starting, then it really is incumbent upon you to get involved either financially or with time and effort or both, because nobody is going to look out for our patients like we do. Our patients, quite frankly, don't know the issues well enough to be able to speak for themselves unless we help them. We're the ones who understand how to take care of patients and how to take care of musculoskeletal injuries and musculoskeletal problems, and therefore, it's incumbent upon us to make sure that the people who are making laws and determining the environment in which we have to take care of our patients understand what the important issues are and what the effect of their decisions will be on our patients. And for me, that's really the main reason why I became really involved in advocacy, because it became clear to me very early that really our patients were not going to have any opportunity to affect their outcome from the standpoint of legislation and regulation without us.
Yeah.
And I just think it's important, and it's frustrating. I mean, we're people that like, we're end result people, right? We like to go to the operating, do something, see the result right away. The patient's home in 3 months feeling great, and you're on to your next patient. Politics doesn't work that way. You get small victories here and there. You get some victories that are just not defeats. But you just have to keep going at it and keep coming stronger and stronger, because it's always going to be us that's going to be responsible for making sure that this happens in a way that's good for patients. And, like the guy said to me, the guy who was the health policy expert, somebody's got to look out for the patients. He's right. And that's us.
Yeah.
Okay. And so it'll always be us. And we should never forget it.
Absolutely. No, I've learned a ton having been on the political advocacy committee. I got interested too. I want to take the best care of my patients I can, and learning about just the ins and outs of how much more goes into that than what I do in the office every day has been really enlightening. And I'm so appreciative of all the people that have gone before me and put in their time and their energy and their dollars to kind of get us to where we are today. And clearly, it's always going to be something we have to keep doing. But I don't know if you guys have any final parting words for our members from the advocacy committee and the world of political advocacy.
I think Jerry hit it around the head. It's really about taking care of the patients. If you think about prior authorization, AMA, studied this, and members presented over 30% adverse events to patients related to delayed pre-authorization. That's direct patient care. So these are things that are very tangible and we can totally relate to, and that's what we need to stay on top of this and contribute, as Jerry said earlier, at the state level, and then as your society, because we all collaborate. That's what we need to do as we go to Capitol Hill.
So thank you for tonight. And I
Yeah.
haven't read this book yet, but I love the title, and I'm going to use it as a sort of a rallying cry for us. Mike Pompeo's got a book out that's called Never Give In. I think that's perfect. That's a perfect sentiment for the way we should look at advocacy in orthopedic surgery in general and ASES in particular. Never give in. Don't give an inch. Make sure you stand tall and go toe to toe with them, because it's our responsibility.
I love it.
Absolutely.
That's
Absolutely.
awesome. Well,
Have a good
thank
night
you
now.
both so much for joining us tonight. We really appreciate it. And thank you to Rachel and Pete for letting us kind of take over and share some stuff about advocacy with the membership. Hope you guys have a great night.